Hello everyone. The topic for discussion for today will be uterine stimulants. These are also known as oxytocics. Basically, they are divided into four categories. First category includes posterior pituitary hormone, and these include oxytocin and desamino-oxytocin. Second category will be of ergot alkaloids, and these includes ergometrine and methyl ergometrine. Third category will be of prostaglandins, and these includes analogues, that is PGE2 analog known as dinoprostone, second PGF2 alpha analog known as dinoprost, third 15 methyl PGF2 alpha analog that is known as carboprost, and fourth and last will be PGE1 analog known as misoprostol. And the last category includes miscellaneous group. These include ethacridine and quinine. Now we will talk about the most commonly used oxytocic that is used in obstetrics, and this will be oxytocin. And regarding oxytocin, it is a nonapeptide that is secreted by the posterior pituitary along with the arginine vasopressin, that is AVP or ADH. Both AVP and oxytocin are synthesized within the nerve cell bodies in supraoptic and paraventricular nuclei of hypothalamus and are transported down the axon and stored in the nerve endings within the neurohypophysis or posterior pituitary. And it is released by stimuli like suckling and parturition. Now we will talk about the actions of oxytocin. First, we will talk about the action on uterus. Oxytocin increases the force and frequency of uterine contractions. With low doses, full relaxation occurs in between, that is physiological, and basal tone increases only with the high doses. Estrogen is going to sensitize the uterus to oxytocin, and it increases the oxytocin receptor, and sensitivity increases progressively in the third trimester, and sharp increase is seen near term, quick fall is seen during puerperium. Now, regarding the mechanism of action of oxytocin on uterus, action of oxytocin on the myometrium, it is independent of innervation, and it acts via the special G protein coupled oxytocin receptor on myometrium that mediates response mainly by depolarization of the muscle fibers and influx of calcium ions. Second action will be seen on breast. Oxytocin is going to contract the myoepithelium of the mammary alveoli, and it forces milk into bigger sinusoids. Oxytocin is going to mediate the milk ejection reflex that is initiated by suckling. On CVS, higher doses of oxytocin causes vasodilation that will lead to brief fall in BP and ultimately results in reflex tachycardia and flushing. And on kidney, higher doses of oxytocin can cause ADH-like action, and it leads to decreased urine output. Now we will talk about the pharmacokinetics of oxytocin. As it is a peptide hormone, so it is inactive orally, so given by IM or IV route and rapidly degraded in liver and kidney, and its T-half is 6 to 12 minutes. Now we will talk about the uses of oxytocin in obstetrics. First most common use is used for induction of labor. Oxytocin is given by slow IV infusion. 5 international unit is diluted in 500 ml of normal saline, making it 10 milli international unit per ml, and is started at the lowest rate and accelerated progressively according to the response. And uterine contractions are then closely monitored, and usually a dose of 2 to 4 international unit total it is needed for the induction of labor. Second use will be seen in uterine inertia. And the uterine inertia means when the uterine contractions are feeble and labor is not progressing satisfactorily, then oxytocin can be infused IV to augment the contractions. And oxytocin is drug of choice for induction of labor as well as for uterine inertia, and it is preferred over the ergometrine and the prostaglandins for these purposes, reason being due to its short T-half and slow IV infusion, intensity of action can be controlled and action can be quickly terminated. Second reason, that is low concentrations allows the normal relaxation in between the contractions so that fetal oxygenation does not suffer. And third reason, lower segment is not contracted due to oxytocin, so fetal descent it is not compromised. And fourth reason will be uterine contractions are consistently augmented. The third use is seen in postpartum hemorrhage or cesarean section. Oxytocin 10 international unit given IM or IV as infusion for an immediate response, especially in hypertensive women in whom ergometrin it is contraindicated. And it acts by forcefully contracting the uterine muscle, which compresses the blood vessels passing through its meshwork to arrest hemorrhage. And fourth use will be seen in breast engorgement. It may occur due to inefficient milk ejection reflex. Oxytocin, it is effective only in such cases but not when the milk secretion is deficient. Intranasal spray may be given few minutes before suckling. So these were the four most common uses where oxytocin is used most commonly in obstetrics. Now we will talk about the adverse effects of oxytocin. Adverse effects, oxytocin adverse effects are basically two adverse effects. First, it is due to injudicious use of oxytocin during labor, and it leads to too strong uterine contractions. Ultimately, it will force the presenting part through the incompletely dilated birth canal and will lead to maternal and fetal soft tissue injury, rupture of uterus, fetal asphyxia, as well as death. Second adverse effect is water intoxication, and it is due to the antidiuretic hormone like action of the large doses which is given along with the IV fluids, especially in toxemia of pregnancy and renal insufficiency. And it is a serious complication.